So this is a presentation on randomized controlled trials for anti-epileptic drugs. There's a lot that can be said on this topic, so it's going to be a whirlwind tour. So the first thing that I always like to remind people is that not everything that can be counted counts, and not everything that counts can be counted. We try in a randomized controlled trial to get in all of the relevant endpoints that would be important when we're treating patients. We're not always completely successful with that, as we're going to talk about throughout the presentation. So the randomized controlled trial is perhaps the most powerful study designed for addressing the therapeutic questions that we have when we are taking care of patients. It's the methodological characteristics of the randomized controlled trial that underlie its power, and the most important of these is randomizing people rather than selecting which drug is best on some a priori knowledge. Allocation concealment, so neither you nor the patient is aware of which treatment they are going to be allocated to. And blinding, same thing, they will not be aware, and if it's double blind, you will not be aware which arm they've been put into. Why do we need randomized controlled trials? Because it has been demonstrated time and time again that when people just, in an open label fashion, put people into an intervention group and look at before they were on that intervention versus after when they're on that intervention, they find results that can be misleading. And a randomized controlled trial in some ways is more likely to actually show the truth, because you can compare to, what may happen just from adding on placebo and people's hopes and expectations, et cetera. So just as an example of different trials that have been done that did not give the right answer when they were open label, the ECIC bypass surgery study way back when showed that there was no decreased risk of stroke after ECIC bypass, even though when it had been done for a long time in an open fashion, it seemed to be very successful. Minocycline was used open label in ALS and thought to be effective, but when it was subjected to a randomized controlled trial, there was no benefit. And in epilepsy, there are some examples as well. There was a famous open label study of cinramide for Lennox-Gastaut syndrome. This was done in the 1980s. When cinramide was given open label to children with Lennox-Gastaut, there was actually something like a 60% reduction in observed seizures reported by the parents. And everybody thought it was going to be a very effective drug. But as you can see, you've never heard of cinramide because it never made it to the clinic. The reason is that the second study was a randomized placebo-controlled trial. They again reproduced a substantial reduction in seizures, but found that that substantial reduction occurred both in the treated group as well as in the control group. Another example is progesterone used for women with catamenial epilepsy. There is still some controversy around whether there is a subgroup of women where this might be effective, but it had been used in open label for some time and seemed to be producing a substantial benefit. But again, when subjected to an NIH placebo-controlled trial, the placebo-controlled trial had to be stopped due to futility. Finally, the last example I'm going to give here is the use of lamotrigine for absence seizures. Although lamotrigine may be effective for absence seizures, in a randomized active control comparison trial, we were able to discover that lamotrigine is at least less effective than valproate or ethosuximide for absence, and there's a question about whether it has an effect at all. So here you have an example of an observational study of progesterone for catamenial epilepsy, and you have a population, some of whom got progesterone and some of whom didn't get progesterone. And then you see an outcome, and again, this is without blinding, it's open label, and you can see that more people did well then did poorly. So, this is compared to some historical control. The original publication was 25 women treated, and 75% seemed to have a seizure decline with a median 54% reduction, which sounds really good as a therapy. But we now know, since the randomized controlled trial failed, that this apparent effect could have been a placebo effect, or it could have been just some variability in patient selection, or it could have just been natural history. But again, when a randomized controlled trial was done, this benefit was not seen. So you have less bias, less chance for a placebo effect that is driving your outcome with the randomized masked trial. And when this was done with the progesterone, we could see that the number of patients who did poorly and the number of patients who did well was equally distributed after randomization in the patients who were randomized to progesterone or to placebo. So overall, randomized controlled trials are meant to minimize bias. So minimize bias in patient selection by randomizing them equally to one arm versus the other. Minimizing bias in who you're going to give which treatment to by masking the treatment and blinding it, and minimize bias in how you analyze the data or evaluate the outcome, because you're always going to analyze what is randomized, which is intention to treat, which we'll talk about later as well. But randomized controlled trials are not perfect. Once you put in a whole system for randomizing, you need sham pills in many cases if it's placebo-controlled. It becomes costly, cumbersome, and time-consuming. In addition, it restricts the population and may limit the generalization or the potential for generalization of the results, because you don't want to enroll patients who would not immediately get treated with some intervention, and this is particularly true for placebo-controlled trials. The reported outcomes may be of limited clinical significance. The study procedures may not mimic true life because we don't know what people are taking, and we get a lot of restriction in how the various treatments might be used. There is a persistent potential for bias, and there's also a chance for false negative results if the study is underpowered. There is always a struggle in clinical trials between what is ideal and what is possible. So that is also known as people are not lab rats. You can't just move them around and tell them you must do this or you must do that. They have a choice of what they want to do. And being enrolled in a randomized controlled trial where things are much more rigorous and controlled and standardized may not be what they want to do, or may not, in fact, mimic what would happen to them if that same treatment was given to them outside of a randomized controlled trial. Many studies have been destroyed because the ideal turned out to be unrecruitable. And there's always a struggle between internal validity within a study, which a control group always gives you, and external validity, which is more whether the results are going to be generalizable to the clinic. The more you control, the less your study bears a resemblance to real life. So the way I look at it is that the randomized controlled trial is like this green figure of all the soldiers lined up in a row. They all know what to do. They're all ready to go, but that is not the battlefield. And once you get into the heat of the battlefield, which is more like the clinic, you are going to find that, in fact, things don't exactly go the way they did in the randomized controlled trial. So when you are choosing a study design for your trial, there are a number of things that need to be considered. The first is, what is your clinical question? What is the hypothesis, and what is the aim of the study? And every study should have a primary hypothesis. There can be secondaries, but there should always be a primary hypothesis, because that's the way you're going to power the study and determine what your sample size is through your primary hypothesis. you're going to be picking a fundamental trial design. Is the trial going to be parallel or crossover? Is there going to be a control group, and what does that control group consist of? What is your sample size? How are you going to blind? Are you going to blind? Is this going to be an add-on study, or is it going to be a monotherapy study? And then you're going to pick the population that goes into the study. What seizure type are they going to have? What are your inclusion and exclusion criteria going to be? And then finally, you're going to talk about the intervention. Maybe you know what your intervention is, but you still have to figure out what is the dose. Are you going to be able to give a flexible dose, or are you going to make everybody take the same dose, knowing that, for example, in epilepsy, it is quite common for different doses to be required for different people. Even if you know your dose, you still have to figure out how you're going to get to that dose. Are you going to titrate? The longer you titrate for, the longer the study goes, the longer a person has to be in a blinded state. So there's a back and forth between rapidly titrating so that you can make the study shorter, but perhaps reducing tolerability versus drawing the titration out a little bit. And then finally, you want to think about your outcome measures. What is the most important outcome measure? What are secondary outcome measures? Are those the things that you really want to know clinically? So let's start with the aim or hypothesis of the study. There are studies that are done for regulatory purposes that provide definitive proof of efficacy for novel therapeutics. And in Europe, the regulators also sometimes want to know that the new therapy is non-inferior to existing anti-epileptic drugs before they put it on the market. That is not really necessary for the U.S. FDA. They want to actually see superiority over usually placebo. Studies can also be done for clinical purposes, not for regulatory purposes, and often clinically relevant studies are going to compare the effectiveness of available therapies in the clinic. And of course, those can be very useful. For example, the UKISS study in the United Kingdom, which compared therapies for infantile spasms, the randomized controlled trial that I already mentioned of newly diagnosed absence treatments. The use of interventions in new populations also can be a clinical outcome. So, for example, I've already proven that this drug is effective for focal epilepsy. Now maybe I'm interested in juvenile myoclonic epilepsy. And there also can be pragmatic studies that try and see whether drug A or drug B is better in the clinic. So, for example, the SANAD study, which stands for Standard and New Anti-Epileptic Drugs, again, a United Kingdom study, which tried to find out whether the newly available drugs were any better than the existing drugs in the clinic. Another pragmatic study was, do we treat immediately after a single seizure, or do we defer treatment until a second seizure has occurred? So these are types of aims that have been used in the past. Again, getting back to the clinical question or hypothesis, I want to remind you that studies can only answer the question that was asked. People usually misinterpret that a little bit when they say, drug A was better than drug B. Well, how was it better? Was it better in terms of tolerability? Was it better in terms of how many people became seizure-free? That may not mean that it's better in terms of weight gain or weight loss, or better in terms of whether people remain on the drug long-term. It can only answer that question as to whether it's people's preferred drug, for example, if that was the question that was asked. So look very carefully about the question that was asked. As I said, there should be a specific clinical question and a specific primary outcome measure, or there may be a problem of multiple hypothesis testing in which if you try and look at 10 different things, just by chance, one of them will come out as statistically significantly different in one arm versus the other. When we create a clinical question, it's most common to use the PCOT format, and I highly recommend that. And that is in population, that's the P, population A, does intervention B versus comparator C, change outcome D over time frame E. And all of those things, the A, the B, the C, the D, and the E, are all incredibly important for you to think about because, again, that will determine what clinical question can be answered. So you should be able to fill in all of those letters. So an example would be, in patients with newly diagnosed focal epilepsy, what is the seizure-free rate in patients placed on levetiracetam when compared to carbamazepine over 1 year of follow-up? One would hope that the primary outcome is going to be clinically meaningful and that it should have clinical significance, not just statistical significance. A moment to talk about clinical equipoise. This provides the justification for a randomized controlled trial, and it represents the collective uncertainty in the medical and scientific community regarding treatment efficacy. So that means that you shouldn't know in advance that one treatment is better than the other. You should have equipoise over which treatment actually is better for people. This is relevant to selection of both the active treatment and the control group. So, for example, if you already know from multiple trials that a drug is better than placebo, you could still do a randomized controlled trial, for example, if you're testing a new population or a new indication where that might not be true. But you've already proven in that population, in that indication, that drug is better than placebo, you may have an issue with equipoise. So the trial design is going to be determined by the aim of the study. Is the study regulatory or is it pragmatic? Do you want a determination of efficacy, which is the percent seizure reduction, versus effectiveness, which brings in tolerability and other issues and whether patients feel that the drug is a benefit to them? Are you going to have an active comparator or are you going to have a placebo comparator? In terms of parallel versus crossover, a lot of people like crossover studies because they're more efficient. You can find out the same thing with fewer patients, sometimes even up to 6-fold fewer. And there's less concern from heterogeneity that may be introduced because you have a large number of patients that you're getting from different types of situations. However, there is a big con in crossover studies, and that is that they are subject to carryover effects. When the subjects are exposed to two different treatments or conditions, what they got in the first instance might influence their experience in the second. So, for example, if you're on an active drug and then you withdraw that drug and there's a withdrawal effect, then the second arm is not going to be the same as the first arm. So drug B administered after drug A is not necessarily the same as drug B administered before drug A. The parallel design has the advantage that there are fewer dropouts. Why? Because if you're in a crossover design, you have to go through two different arms, and that's going to take a lot longer for an individual patient. There's less unblinding. Why? Because if you're in a crossover study and you got the active treatment in the first arm, then you probably will know when you're crossed over to placebo and vice versa. And for these reasons, the FDA accepts parallel studies much more readily than they do crossover studies in most instances. Let's talk about control group selection. An active control provides a reference point which is useful to clinicians. So in other words, I don't want to know that this new drug is better than nothing, because I'm not planning to give nothing to my patients. I want to know that it's better than something else that I could give. Currently, this is essentially the only control group that can be used in trials with newly diagnosed patients, since obviously you can't give placebo to somebody that you know has an active disease. Placebo-controlled or dose-controlled studies are the most valid control group, and there's little doubt about the internal validity that that provides. However, it does raise potential safety issues for patients, even in an add-on situation. There was a study that's cited at the bottom of this slide, which showed that if you took a very large number of trials and looked at the patients who had been randomized to active arms versus as add-on, versus placebo arms, that the number of people who died of SUDEP was much higher in those that had been randomized to the placebo arm, which suggests that withholding additional active treatment or withholding active attempts to improve somebody's seizure situation, even for the 4 or 5 months that they might be in a randomized placebo-controlled trial, might be enough to cause permanent harm or death. On this slide, we see a standard randomized controlled trial that is done for regulatory purposes as add-on. So you have somebody on their standard background anti-epileptic drugs, and you monitor them for some period of time, usually 8 weeks, to determine what their seizure frequency is in baseline. And we usually have a minimum number of seizures that's required for them to be randomized. Randomization occurs usually to placebo or 2 different doses, sometimes 1 dose, sometimes 3 doses of the intervention, which is the new drug. And as you can see from this picture in the orange, usually the patient is titrated over some titration phase to each of the doses. Once they're up on the titration phase, that's the start of the maintenance phase, and that's the most important phase where patients are on fixed doses of these the placebo or the multiple doses of the intervention, and then they're usually followed for approximately 12 weeks, and the seizure frequency is compared. You can see on this slide that there is an opportunity in some studies, but not all, if the patient is not tolerating the drug, to drop back to a slightly lower and more comfortable dose. So the patients in each of the arms, even though they're randomized to dose X, may not actually ever achieve dose X. When patients enter an add-on placebo-controlled trial, if they're randomized to placebo, they may not change therapy for 6 or more months once you add up the baseline phase, the titration phase, and the treatment phase. And as I mentioned, patients randomized to placebo have a 5-fold increased risk of sudden unexplained death compared to the active arm. For some patients, it's highly appropriate to enter a placebo-controlled trial because there may not be any other options. They're at the end of the line. They live in a region where they can't have access to new anti-epileptic drugs except through a trial. They don't want to try other things that are out in the marketplace. But there remains a continued question as to at what point placebo is appropriate for anybody who doesn't fall into those categories. Let me talk a little bit about equivalence, non-inferiority, and superiority. So there are some studies that demonstrate equivalence. We don't use that very much in epilepsy, some that are trying to show non-inferiority and some that are trying to show superiority. Most regulatory trials in the U.S., as I said, are for a superiority outcome. And you can see in this figure that when you look at the chance that both groups do exactly the same, that's the middle bar. If one group does better than the other, you get into superiority, and anything that is statistically significant, where one group does better than the other, will give you a superiority outcome. Equivalence would be the drug is neither better or worse. One arm is neither better or worse than the other arm. In order to figure out whether a drug is neither better or worse by some non-inferiority and non-superiority margin, then you would actually have to have a large sample size. And that's why some studies, instead of trying to look at equivalence, try and show non-inferiority, where you can show that the drug by some non-inferiority margin is not inferior to the other drug, and you don't care whether it's the same or it's superior. That turns out to require less patients than an equivalence design, and that's why you will see a lot of European studies being done as non-inferiority studies. So again, along the same theme of superiority versus non-inferiority, you can think of it as a horse race. Do you want one horse to win, or do you want two horses to come in at the same time? Superiority proves that a study drug has efficacy by showing a significant difference between the drug that is the test drug and whatever the control arm is. Usually the comparator is a placebo control because we don't have any drugs right now that are so much better that they could actually beat an active control. Sometimes there could be a dose comparison between a low dose of a drug or a high dose of a drug. Non-inferiority studies prove that the efficacy or effectiveness of a new drug is not significantly less than a standard drug, and usually the comparator or control will be a standard anti-epileptic drug, and hopefully effective doses have been selected. Non-inferiority or equivalence studies are different from conventional studies for a number of reasons. As shown in the figure that I showed you before, they're dependent on confidence intervals, not point estimates of difference. Intent to treat analysis is no longer conservative. You should, in fact, compare protocol per protocol populations. For example, a patient who doesn't take the drug or drops out will drive towards a no difference outcome, and that actually may be incorrect. Intention to treat is particularly hard to assess when you're crossing patients over to another treatment arm and when that is allowed, as in the SANAD study. They were analyzed based on what they were originally randomized to. So let's say the patient was randomized to carbamazepine, even if they took it for, 5 days, and then they crossed over and took lamotrigine instead, they were randomized in the carbamazepine arm. That is true intention to treat, but certainly it may make a very messy analysis. When you're dealing with non-inferiority, there's also another problem, and this is the problem that is of great concern to U.S. regulators and the FDA, and that is, what if two treatments are not equally effective, but actually equally as ineffective? So let's say you give carbamazepine versus levetiracetam in newly diagnosed patients, and you show no difference, but in fact those patients were never going to have another seizure because they have very mild epilepsy, and so you really didn't need the drug after all. Some of them were going to have seizures and some of them were not going to. For this reason, there is a guideline that's supposed to be an international guideline for studies called the ICH guideline, or the International Conference of Harmonization, and they have some verbiage that says that for equivalence trials to be used as evidence of efficacy, there must be historical evidence of sensitivity to drug effect. That is, that similarly designed trials have regularly distinguished effective treatments from less effective or ineffective treatments. The problem with a no difference outcome, as I mentioned on the last slide is that poor trial methodology may actually drive towards a no difference outcome. What if you did one of these studies, for example, and you only enrolled patients with non-epileptic seizures where intervention with a drug would not actually differentiate their outcome? So poor trial methodology could be rewarded in a non-inferiority study. Power calculations are also critical, and also determination of a clinically significant difference that you want to exclude. So for a no difference outcome, if there's a 5% difference between the groups, is that important? Is there a 10% difference between the groups? Is that important? Figuring out what the clinically significant difference is and including enough patients to be able to rule out that such a difference exists is very important in non-inferiority studies, and that's why they tend to be much, much larger than superiority studies. So here's an example of an active control and a treatment, and here you're seeing that 40% of the patients are seizure-free in the study, and it looks like this is a good non-inferiority or equivalence, and you're presuming that the placebo, had it been included in the study, would have been at some point lower than either the active group or the treated group. But the concern is always that the placebo, if added in, actually would be exactly the same point as the active and the treatment group. And although that seems unlikely in epilepsy, we have found, for example, in depression studies where a lot of people improve when they're put on antidepressant A compared to antidepressant B, but then when you put in a placebo group, many, many people and the same number of people improve when they are on the placebo as on the active drug. So we always have to keep that in mind, and the ability of a study to differentiate between treatments in an appropriate way is called assay sensitivity. We're going to go on to talk about sample size. So a randomized controlled trial should always include discussion of sample size and power. Failure to demonstrate a treatment effect in an underpowered study may represent a type 2 or false negative error. Demonstration of a treatment effect or equivalence in an underpowered study may represent a type 1 or false positive error, as we just discussed. So back to the issue of confidence intervals, one way to evaluate is to look at the confidence interval that surrounds the point estimate of the treatment effect. And if you have a broad confidence interval, and particularly if it spans unity, then you're going to be less certain of whether your results are correct compared to a narrow confidence interval. Blinding is necessary to reduce bias, but there are pros and cons of blinding in a study. The big pro of blinding is that it reduces the risk of outcome assessment bias. If I think that rashes are more likely on carbamazepine than levetiracetam, then when I see a rash in somebody who I know is on levetiracetam, I might say, oh, that's probably not drug, let it ride. Whereas if I saw it in somebody on carbamazepine, I'd say stop the drug, that might be an allergy. And in fact, in a randomized controlled trial in newly diagnosed patients of carbamazepine versus levetiracetam, blinded, surprisingly, there was equal number of dropouts due to rash in both arms. But the cons of blinding is that it really hurts recruitment. People like to know what they're taking. They don't like to be in a position of not knowing. Specific groups may be excluded. So, for example, if you know one arm is valproic acid, you may not want to enroll women of childbearing age into that arm. And it departs from everyday practice, obviously. And finally, once the treatment is over, once the treatment arm is over, you have to break the blind, and that may influence the trial as well. And there may be higher dropout rates if people don't know what they're on, and they are concerned about an adverse event. finally, blinding increases expense of the trial. So the big pro of blinding is it increases internal validity, but it is at the expense of external validity or generalizability, as is often the case. A word about monotherapy. In the past, complex monotherapy studies were necessary for regulatory approval because the regulators were not certain that a drug that worked as an add-on would also work as a monotherapy. So there were trial designs such as withdrawal to monotherapy and historical control. In fall of 2017, there was a change in the FDA perspective, and these trials were no longer considered to be necessary, and the FDA made a ruling that monotherapy efficacy could be extrapolated from add-on studies. Once the add-on studies that are usually done for regulatory purposes are completed, the company has to do some pharmacokinetics in monotherapy and some safety studies in monotherapy, and once they do that, they are able to get monotherapy approval. So now monotherapy trials are only necessary in Europe, and they are done as active control non-inferiority studies. In addition to that, some pragmatic trials, as I mentioned before, are done in monotherapy, such as the SANAD study. So often pragmatic trials will do monotherapy. We're now getting to population to enroll in the trial, and there are some considerations for patient selection in epilepsy trials. So sometimes you've done some preclinical studies, and based on that, you can predict that one population will do better than another. You have to decide what epilepsy syndrome you're going to tackle first for a new therapeutic intervention. Within that syndrome, you may not be testing all seizure types, or maybe, and particularly recently, people have been talking about testing a seizure type even if it spans across a number of epilepsy syndromes, like generalized tonic-clonic, tonic-clonic convulsion, whether it's generalized or focal to bilateral tonic-clonic. You want to consider what other drugs you're going to allow people to be on, and that's going to have a lot to do with whether you think the drug that you're adding in is going to have any drug interactions with the drugs that people are already on. And all of these things are going to lead to a set of inclusion and exclusion criteria for your study. So you can choose them by syndrome, you can choose them by seizure type. Lately, people have been selected by etiology. For example, there was a study of everolimus use in people with seizures due to tuberous sclerosis, and patients were enrolled whether they had infantile epileptic spasms, whether they had focal seizures, whether they had Lennox-Gastaut. So it is possible to do that. You can enroll people by their genetics. Dravet is a genetic epilepsy. You can require people to have an SCN1A mutation, KCNQ2 mutation, CDKL5 mutation, and some trials now are selecting by genetics. We don't know which of these is appropriate and for which intervention. That is an issue that is still under active discussion. Unfortunately, the generalizability of our studies has been limited by the fact that the standard add-on placebo-controlled trial that is usually done initially for approval of new anti-epileptic drugs does limit the type of patients that can go in. So usually they're between age 16 and 65, so you don't really have a lot of elderly people in it. They're very treatment resistant, having failed more than 2 drugs, currently receiving 1 to 3 drugs with usually more than 3 to 4 seizures a month if it's a focal epilepsy study, and more than 1 seizure a month if it's a generalized epilepsy study. So that means that you may not know how that drug is going to perform in less ill patients. The patients often cannot come into the study if they've had status epilepticus. serious psychiatric illness or medical illnesses. So when the drug goes into the clinic for the first time after the randomized controlled trials, there may be a lot of patients, types of patients who are going to be exposed for the first time when the drug goes into the clinic. Seizure frequency is a big problem. I just showed you that the seizure frequency in randomized controlled regulatory trials tends to be very high. It has to be sufficiently high that a new compound will have a measurable effect. And there would be different considerations if the outcome measure is seizure freedom, but unfortunately, usually it's not in our regulatory trials. It's median % seizure reduction. And in order to show that over a short period of 3 months, you need a relatively high seizure frequency just statistically. If the seizure frequency is lower, you're going to have to compensate with a larger number of patients or a longer observation period, neither of which are very easy, particularly if the study is placebo-controlled. And seizure counting is also confounded by patients often having clusters or flurries where patients may not actually know exactly how many seizures they're having in a flurry, and it may be difficult to count. And you also have to worry about patients who may have, let's say, that 3 or 4 seizures a month, but they all come in one day, and then 27 days they're not having seizures. So that pattern can be very problematic. So I'm going to give you an example here. This is from Bob Fisher, and it shows a patient keeping a seizure diary in each one of these lines is a seizure. And imagine, and you can see that perhaps it's related to the menstrual cycle, perhaps it's not, but imagine that the patient is randomized right before this flurry of seizures happens, and the red bar here represents randomization. And you can see that suddenly it seems like perhaps there were fewer seizures during baseline. But if the randomization is moved and suddenly it's after that flurry of seizures, suddenly it seems as if after they're randomized, they have fewer seizures and maybe the treatment is working. So in this case, the presence of irregular seizure patterns may contribute to what appears to be a placebo effect. So we have to make sure that seizures are countable, and issues with seizure counting, in addition to the ones that I just mentioned, include in children, and particularly children with developmental delay. They may have tics and stereotypies that are difficult to distinguish between those and actual seizures. We don't want to enroll patients, obviously, who have non-epileptic events. It is very common for patients not to be aware of their own seizures. So we have to enroll patients who can actually count their own seizures or who have reliable observers. And I already mentioned the issue of flurries and clusters. So this came into play, and a great example that I often show is the Lennox-Gastaut randomized placebo-controlled trial of clobazam. The primary outcome measure was the reduction in drop seizures. And you can see drop seizures where the patient falls to the ground is a very nice countable seizure event. And you can see that the blue placebo group did not have a very significant reduction. And there was a nice dose-response relationship with the low, medium, and high dose on the impact on the frequency of drop seizures up until the highest dose having a 68% reduction in drop seizures, which is very nice. However, if they had actually counted all seizures, you can see that that was not, it still seemed to have a dose response, but the Middle dose and the low dose actually showed an increase in all seizure types. The placebo arm had a substantial increase, probably because people were observing more closely, and only the high dose showed a reduction in seizures. So when we counted everything and not just the very easily countable drop seizures, we did not get probably the correct response or the correct outcome. Finally, we're going to talk about issues with intervention. You need to know, as I mentioned, the dose and titration prior to planning a trial. Too rapid a titration could increase the dropout rate. Blinding often means that there is not an ability to adjust a dose after randomization. And in equivalence trials, as you can imagine, dose selection is very critical, because if you overdose, you're going to increase the appearance of side effects. If you underdose, you may decrease the ability of the drug to control seizures. So you have to pick the clinically relevant dose, and that is not always easy to determine. Looking at outcome measures, endpoints are often selected out of expediency rather than selecting the most clinically relevant endpoint. And that's an example of this is median percent reduction, which isn't necessarily the outcome that most of us are particularly interested in. You can consider both efficacy and tolerability in an outcome, and sometimes these are combined for what is called an effectiveness outcome. So you can think of this as if a drug is able to reduce seizures by 90%, but only when everybody sleeps through 90% of the day, that's not going to be a very effective drug in the clinic, but it may appear very efficacious in a randomized controlled trial. So if you really want to know whether it's effective, you're going to consider both of those outcomes. Often regulatory outcomes are not that easy to translate into clinical relevance. So change in median seizure frequency, we use that because it's a continuous variable and easier to handle statistically, and you don't lose data. Seizures are non-parametric and their distributions are skewed because seizure frequency can only be reduced by 100%, but it can increase infinitely. So that's what causes the skew in the distribution. So you have to use a non-parametric statistic to look at the outcome. A median 15% reduction in seizure frequency could be very robust statistically, but may be of questionable interest to a clinician. Change in median seizure frequency, a few outliers with very high seizure frequencies can be problematic, and often we transform those high seizure frequencies in order to eliminate that problem. The alternative endpoint that is used mostly by the European regulators for outcome of regulatory trials is the responder rate. And this is a categorical measure such as achievement or a 50% or greater reduction in seizure frequency. The reason that was picked is that it's considered to be a clinically meaningful endpoint for people. So how many people achieved enough of a reduction to be clinically meaningful. But the picking of this type of endpoint means that you lose information and there's a reduction in statistical efficiency. And you should always look at aggravation as a separate issue if you're looking at a 50% or greater reduction, because there are examples where more patients in the treatment arm than the placebo arm had a 50% reduction, but also more patients had an increase than in the placebo arm. So you're looking for a U-shaped curve. And there's still a question about whether responder rate truly is more clinically meaningful than median percent reduction. I talked already a little bit about efficacy versus effectiveness. So efficacy is the demonstrated effect during a clinical trial. It only assesses the outcome that was predetermined, and it assesses it at the fixed doses that were chosen in the trial, the fixed titration schedules, which may not be optimized and may be, again, picked out of expediency to shorten the trial duration. They show the effect over the short term, usually only 3 months of a trial. The patients may be highly motivated to stay in the trial over the 3 months, even if they feel like they're overdosed. So they may be getting more benefit than they would be in real life, but they're just waiting till the end of the randomization period so they can ask their doctor to lower the dose. And again, these trials are often done as add-on, which may actually reduce the efficacy that you see in a randomized controlled trial. Efficacy is often represented as a single number. For example, dose X reduced seizures by a median of 36%, but life often, as we know, is really not that simple. So an example of what I'm talking about is Tiagabine. Here you can see different doses of Tiagabine versus placebo showing an increasing median percent seizure reduction as you go higher in dose, which is exactly what you would like to see. But I'm sure none of you have ever prescribed Tiagabine, younger people, and that is because what that didn't show you was the other side of the coin, which is how many people had a 100% increase in seizures. And unfortunately, you can see that there also is a dose-response relationship with more and more patients at higher and higher doses having a higher median percent reduction. Now let's talk about effectiveness. Effectiveness is considered to be that elusive ability to control seizures in my clinic, in your clinic, not in a trial. So it may not be quantified in a randomized controlled trial. For one thing, it may relate to an endpoint that was not evaluated, like the patients really liked being on this drug, they felt well on it, they wanted to stay on it. The drug may be better or worse for patients who do not conform to the study inclusion criteria. So in my clinic, the patients who weren't candidates for the trial feel very well or do well on the drug. The drug may be better tolerated or more efficacious when one can manipulate in the clinic and increase or decrease the dose of the new drug or reduce the dose of a background drug to make people more comfortable. So all of these things may mean that the effectiveness in the clinic turns out to be either better or worse than the efficacy that was determined in a randomized controlled trial. One can look at other endpoints other than those that are used in a regulatory trial. Seizure severity is difficult to measure. There are seizure severity scales, but it's been difficult to translate them to an improvement in the clinic. Non-seizure related outcomes are important, quality of life, cognitive outcomes, and studies can assess these. Non-seizure related outcomes are unlikely to be useful, obviously, if you don't get the seizures better and you're talking about a seizure drug. Recently, we've been interested in time to event outcomes, which may shorten participation in a trial for a patient who is not doing well, so they don't linger on placebo. Time to first or second seizure, or time to baseline seizure rate, so it can be very efficient and reduce the time on an ineffective therapy, but you can lose the control group too early, and therefore maybe not be able to compare other endpoints such as safety. Back to intention to treat. The principle of intention to treat is that subjects allocated to a treatment group should be followed up, assessed, and analyzed as a member of that group, irrespective of their compliance with the planned course of treatment. And again, that is from the International Conference of Harmonization document. So that means that you analyze all subjects in the group that they were randomized to whether they take their drug or not. And this is the most conservative analysis. Why do we do that? Let's say that you have patients who are randomized to treatment versus control or treatment A versus treatment B, and half of the people in treatment A drop out because they're not getting a benefit, and only the patients who are getting a slight benefit stay in, whereas in treatment B, everybody stays in. Then treatment A may look like it's better when actually it is not. Alternatives to intention to treat or modified intention to treat, where you analyze subjects who only have gotten some intervention so that you can see what that intervention did. Or there is a per protocol analysis, but again, that could be a biased analysis, which analyzes subjects who comply according to the protocol. So again, per protocol analyses can introduce bias if the dropouts were non-random and were more frequent for whatever reason in one group versus another. All studies should be done using the CONSORT statement. This is for reporting. This is the Consolidated Standards of Reporting Trials. This is a consensus document regarding the reporting results of randomized controlled trials. There is a 22-item checklist. And you need to include a flow diagram that exactly tells you what happened to each participant. So this is an example of a Perampanel study and the disposition of patients, every patient at every arm, why they discontinued the study, and what happened to them. Obviously, when people drop out, if you're using an intention to treat, you still have to tell us what happened to that patient and what their outcome was. So how do you report an outcome in somebody who's dropped out of the trial? Well, for most regulatory trials up to this point, we use something called last observation carried forward. So in that last observation carried forward, however they did up until the point of discontinuation is what their outcome is. So if they had a 50% reduction, then their outcome is a 50% reduction. There's also a worst case scenario where you say that everybody who dropped out did not benefit from the treatment. That's a different way to look at it. You can count dropouts in a sensitivity analysis in more than one way. You can look at them as either all responders or all non-responders and see how that impacts your outcome. The best case scenario is you don't have to worry because the outcome has not been substantially impacted by dropouts. Although last observation carried forward is the preferred analysis of regulatory authorities, there can be issues. So again, if the patient drops out, the data obtained to that point in time is used as the outcome, but it may be a confounder. So drugs administered at tolerated doses, patients are less likely to drop due to severe adverse events, but more likely to drop if they have mild or moderate adverse events coupled with a lack of effect. And in that case, a last observation carried forward is the conservative analysis. However, if a drug is administered at a higher than therapeutic dose, early dropouts means that last observation carried forward may inflate the proportion that are seizure-free because patients may actually drop out before they even have time to have a seizure. And then that may be the less conservative analysis. So, for example, in an OXCARBAZEPINE trial, patients who completed the study, there was only 22%. There was 22% seizure-free in the intent to treat last observation carried forward. However, if you looked at only the patients who completed the study, then there was only 9% who were seizure-free. So last observation carried forward, counting the dropouts who were seizure-free and who obviously couldn't have benefited from the drug if they can't tolerate it, really inflated the number of patients who appeared to be seizure-free. And finally, we want to talk about this very interesting study in the New England Journal that talked about randomized controlled trials and evidence requiring evidence to the height of absurdity. So in this study, which was a study, supposedly a meta-analysis of parachute use to prevent death and major trauma related to gravitational challenge, they found that there were no randomized controlled trials of parachute use, and that the basis for parachute use, therefore, could be considered to be purely observational and not proven. So, in other words, obviously there cannot be a study of the parachute in a randomized controlled trial, and they said that individuals who insist that all interventions need to be validated by a randomized controlled trial need to be the first to volunteer for the placebo-controlled parachute study and need to come down to earth with a bump. Not all interventions can be subjected to randomized controlled trials. And as Albert Einstein said, information is not knowledge.